Our young black MSM were very articulate in describing some of these consequences of housing instability, and being placed in risky sexual situations was one consequence. And after his mother put him out of the house, one young man told me what happened to him, and he said this: I ended up house hopping. I ended up staying with a crowd of older gay men, and that's kind of what promoted me to be sexually active a lot. Then I started smoking, started drinking around them. They would think, okay, you're well old enough, you're mature enough, and give me a drink. And most of them would do it just for the purpose of trying to lay down with me. I asked, and how old were you when you got put out of the house? 15. And during another interview, one young man told me how beginning at the age of 14, he had to trade sex in order to acquire money, food, and housing, and how he also engaged in substance use in order to cope with the pain of being forced to leave his home. When I asked him, what was your financial situation like during the times you were prostituting yourself? He responded, not stable. It was from when I was 14 to 17. My father had just put me out of the house. Why did your father put you out of the house, I asked. Because I came out of the closet. I told him I was gay. Among the 44 young MSM who completed structured interviews, housing instability was common. We found that 38% of the young black MSM had ever changed their living situation because of their family's reaction to their sexual orientation, versus only 13% of the non-black MSM. But another common result of homophobia was internalized homophobia. And this basically occurred when young MSM embraced negative views about themselves. And overall, this was a very common thing being mentioned by 13 out of the 18 men who we interviewed. For these men, religion and spirituality were very strongly connected with internalized homophobia. And this was particularly true for black MSM. Common expressions of it indicated that homosexuality is a sin, and men oftentimes articulated their need to repent from homosexuality because of its fundamental wrongness. And so to illustrate, when I asked one young man about strategies that could have prevented him from acquiring HIV, during the course of that conversation, he told me this: I've always felt like if I die tomorrow, I'm going to hell. You know what I'm saying? Just because I think to be gay is a sin. Now, our analyses on internalized homophobia are still ongoing, but one of the things we're seeing in the data is that internalized homophobia had very severe consequences, and this was particularly true for the non-black MSM. And one of these consequences was maladaptive coping strategies, or simply bad health behaviors, in order to deal with the pain of internalized homophobia and the stress of homophobia as a social determinant of health. When I asked one young Latino man what resulted in him becoming infected, he told me that he always used drugs and alcohol before and during sex because he could never come to terms with his gay sexuality. And although this man wasn't black per se, his narrative reminds us of some literature pointing to black MSM having a relatively high likelihood of using substances during sex, but also substance use during sex being linked to internalized homophobia in order to dull themselves through having sex. And so he told me this: I never had interviews. Nearly half of the young black MSM versus only 20% of the non-black MSM believe that sex between two men is a sin. And the majority of the young black men wished they weren't attracted to men and thought that their sexuality had hurt or embarrassed their family. And note that the young black MSM who we interviewed were about twice as likely to think in these ways as their non-black counterparts. Although our analyses are ongoing, these data are important because our participants' stories are providing us what we believe to be models of pathways to HIV transmission for young MSM and young black MSM in particular. Participants describe how homophobia resulted in housing instability, as well as internalized homophobia. And respectively, these factors resulted in men being placed in risky sexual situations, particularly having sex with older men and having to trade sex, as well as maladaptive coping strategies like drug use during sex. And men themselves describe how these factors resulted in them, or men within the community, engaging in unprotected anal intercourse, which we know could result in HIV transmission. So I spent some time talking about homophobia as a social determinant of health and a social determinant of HIV prevention for MSM in particular. But I would like to think about biphobia, because within our community, the LGBT community as well as the society as a whole, we have a significant amount of bisexual stigma that affects bisexual men and bisexual black men in particular. So I raised a question, why does biphobia matter for black MSMW? Well, as I've just outlined, we know that homophobia is associated with HIV risk for black MSM. So I asked the question, why wouldn't biphobia also in some way be associated with HIV risk for black MSMW? Greg Herrick, in a study in the early 2000s, showed us that attitudes toward bisexual men are more negative than attitudes toward gay men. And in addition to the fact that biphobia is incurred from both straight and gay communities, making its impact potentially more intense, Brian Dodge and some others in this room have outlined some of the adverse mental health outcomes that are unique to bisexual men, many of which stem directly from bisexual stigma in both the LGBT community and the United States overall population. So in light of these issues, I wrote my Ph.D. dissertation to examine if biphobia could be a reason that bisexual men exhibit higher levels of risk along some risk behaviors than MSM in the United States. And I used the 2002 cycle of the National Survey of Family Growth, which is a nationally representative sample of men between the ages of 15 and 44 years. And here I used a subsample of 3,875 sexually active men, or those who had engaged in sex with at least one woman and one man during the previous year. In one chapter of my dissertation, I examined differences in HIV testing and other risk behaviors, comparing MSM and MSMW of all races. And the article for this part of the analysis appears in your conference packet. But in anticipation of today's meeting, I repeated analysis of these data using only the 41 black MSM and MSMW. And these data are unpublished. And the reason for this analysis was that I wanted to investigate sexual health behaviors using a nationally representative probability-based sample, because most of the studies that have looked at black MSMW have sampled these men with respect to their risk behaviors. And although the sample was very small, having only 41 men, 19 MSMW and 22 MSM, black MSMW and MSM were so different along the risk behaviors that I examined that I found statistically significant differences when I compared them. Relative to black MSMW were much more likely to have engaged in past year sex work, sex with an HIV-positive or intravenous drug-using partner, injecting drug use, intoxication during sex, sex with 3 or more partners during the previous year, as well as ever be diagnosed with genital warts, herpes, or syphilis. Although the small sample size certainly is a limitation, note that almost a third of the black MSMW had engaged in sex work or injecting drug use versus none of the black MSM. And again, this sample is nationally representative. Now, in the literature, I and other researchers have argued that one reason black MSMW may exhibit some higher levels of risk relative to black MSM is that they're poorer than black MSM and have to engage in risky behaviors for survival purposes. So to kind of get at this issue and kind of adjust for this, I ran multivariate models to control for the effective income when looking at black MSMW and relative to black MSM, and found that even after controlling for income, black MSMW still had a greater odds of engaging in these behaviors. So these data are useful because they make us think of possible reasons why black MSMW may exhibit some greater levels of risk behavior relative to black MSM. Now, as I posited in my dissertation, as well as the article in your packet, we know that biphobia results in low acceptance as well as hostility toward bisexual men. And some theorists have argued that this could result in internalized biphobia, whereby bisexual men think negatively of themselves and engage in some adverse risk behaviors as a response to that. As well, many of us have highlighted some of the adverse mental health outcomes that are unique to bisexual men that may also place bisexual men at risk. We also know that there is marginalization of bisexual men within the LGBT community, and this may decrease bisexual men's perceived risk for HIV. Of course, conclusions are tenuous, making it necessary to rely on theory to understand the relationship between bisexuality and risk. So in summary, evidence suggests that homophobia is an important social determinant of HIV risk among Black MSM. And given what we know about bisexuality, biphobia may indeed be a determinant of HIV risk among Black MSMW, although biphobia certainly has been studied less extensively than homophobia has. So what do we do about this? I believe that we must consciously and deliberately intervene on homophobia and biphobia as social determinants of health in order to improve HIV-related health outcomes for Black MSM and Black MSMW. I think that we need to develop interventions that address sexual minority stigma as types of oppression at the societal level. And at CDC, in the Division of HIV/AIDS Prevention, we currently have a structural intervention work group that is conducting formative work on the types of social interventions that can be done to address racism, which we've heard a lot about today, homophobia, as well as poverty as key social determinants of health for marginalized communities. It's also important for us as clinicians, scientists, and members of the lay public to promote critical dialogue on the adverse effects of homophobia and biphobia as demonstrated in the scientific literature. And I think it's also important for us to capitalize on existing social marketing campaigns that promote human rights, such as those we've seen being done with the No Hate campaign as well as the Human Rights campaign. And a good example of this is Milwaukee's Gay Neighbor campaign. And this was developed by LGBTQ organizations in Milwaukee to reduce homophobia. Pictures like this one appear on billboards as well as in some media publications in order to hopefully reduce homophobia. And some of our CDC partners in Milwaukee are using tenets of this campaign to design a structural social intervention to address homophobia directly for the Black community, given some of the findings that we had regarding homophobia in young Black MSM in Milwaukee.